Welcome to Between Data and Risk podcast. Today we'll talk about the responsibility related to using patients' data with our guest, JD Whitlock, CIO of Dayton Children's Hospital. Stay tuned. If you're a business owner or senior manager, you probably had more than enough about all the wonderful opportunities awaiting you in the era of digitalization.
Whether it is big data, cloud, data science, or whatever buzzword is currently trendy.
If you would like to hear someone dissecting these claims and showing you what it actually takes to improve business processes, you're in the right place.
This is Between Data and Risk, where we discuss real-life examples of what works and what doesn't in the world of business operations.
Hi, I'm your friendly neighborhood data guy, Dr. Marian, and with me is my co-host, Artur Cognition Shared Solutions Chief Risk and Strategy Officer.
Hello.
Welcome to this episode of Between Data and Risk. Today we'll take a look at data science in the context of medical services and patient data. We have with us JD Whitlock, healthcare consultant and CIO at Dayton Children's Hospital, who agreed to share some of his experiences with us. Hello, JD.
Hello, pleasure to be here.
Yes, it's a pleasure to have you with us. We know how sensitive is patient data in today's world. And I believe many of people in our audience would like to maybe understand better how is it protected when they send their children to the hospital, or at least how it should be protected. We believe that Dayton is, I think, I'm not sure if it was the first or next time, the best children's hospital in the US. So I believe it's
we
done right.
that it was awarded that accolade at some point.
So the question is, what should they expect from hospitals if they would ask, okay, so now you have my child, you have his or her medical record and a lot of other sensitive data. How do you protect it, and what should they hear?
Yeah, sure thing. So the good news is that in the United States, at least, the HIPAA laws that have been around since 1996 are pretty clear about how we are supposed to protect patient data. Now, obviously, with the risks of cybercrime and ransomware, that's the single biggest risk. There are other risks that we have, operational errors that result in, in patient data being inappropriately released. Despite the fact that, we have electronic health records and patient portals and all that, there's still an awful lot of the after visit summary that most patients get after they see their doctor. It's still printed out just for convenience sake to have that information of the medication you were just prescribed, or make sure you do this when you go home. It's people still want to have that printed out. And if you hand the wrong one to the wrong patient, then technically that's a breach of. But at least we have, at least the HIPAA regulations are very well understood because they've been around for a long time. What's changed recently and what patients need to be very careful about is with some of the more recent government regulations on interoperability that are a good thing because they give patients more rights to get their record, or in our case, their kid's record, electronically, quickly, downloaded into wherever they want to send it to, including third-party applications. There's a risk there that patients are downloading their family members' records into lots of different applications, and perhaps not all of those applications have their best interests at heart. And that, interestingly enough, is not protected, because if it is self-disclosed by the patient or the patient's proxy, it's not covered by HIPAA. So now the government's talking about, well, maybe we should fix that. It should be protected based on the type of information, not, and you shouldn't have that loophole for patients releasing their own data. So that's one thing of concern. What should our patient families expect of us at Dayton Children as well? That we have a competent cybersecurity team. We're doing everything we can to avoid worst case scenarios of cybercrime, ransomware, et cetera, et cetera. So that's something we obviously pay a lot of attention to.
It's interesting, the parallels between what you just described and the developments in similar space in the financial industry, because protection of financial information has been around for equally long time. But the recent kind of developments in open banking standards, where you can make your account data available to any third party in order to supposedly kind of consolidate your financial information in one place. But as you say, not all of those applications have the client's best interest in mind. And it almost seems like we're trying to bring a lot of convenience, but at the same time, people's mentality and the ability of the customers themselves is not kind of advanced enough to make full use of it, which kind of leads to paradoxes like when you're trying to make a simple payment nowadays. I remember I was making a payment recently, and I had to enter my password. Then I had to watch a short video on fraud. Then I had to enter another password that I received on SMS. And frankly, it would have been just easier just to call the bank and do it, because they're trying to protect me against myself. And I suppose similar things apply in the healthcare industry, where you want patients to have that access to information, because obviously it can be critical, it can be life-saving. It's not just about convenience, but at the same time, you want to protect them against making, frankly, stupid mistakes sometimes. Right?
I have a question from a data point of view, because I'm not sure how the things work in the States. Maybe I hope I'm not asking the obvious question, but if I'm in the hospital in the States and my doctor needs my medical information, let's say I'm unconscious, how easy it is for the doctors to get information from other medical facilities about, did anyone treat me? Did anyone, I don't know, notice that I have some allergies? I personally have for penicillin, which is pretty widely used in the UK. And they were all happy that I knew about it, but it could be administered to me if I would be, an example, unconscious. How open and transparent is this on the professional level?
Classic example is you are someplace besides where you normally are. You're in a motor vehicle accident. They wheel you into the emergency room. You're unconscious, and they administer some medication that you are horribly allergic to, and makes your condition worse if it doesn't kill you. Right? Mm-hmm. How do we do that? The bad news is that's not completely solved yet. Good news is it's getting dramatically better quickly with a lot of the regulation around that. And specifically in the United States, what's happening is the government is moving quickly towards setting up the legal frameworks, the trust frameworks to basically you're saying, hey, James David Whitlock, born on this day in 1966, is looking for his records, and send that out. And do you have this patient in your record? And return that JD is allergic to medication. So don't. A common one in emergency care is some people are allergic to the contrast that's going into the imaging studies. If you're head injury and you're doing a CT with contrast, but in the middle of a trauma, the last thing you want to do is stick a bunch of contrast in somebody that's allergic to contrast. So the good news is getting better, way better than it was just a few years ago. However, it also depends on the doctor that you go to and the electronic health record that they're on. And quite honestly, if you go to a small independent practice and they're on a not very good electronic health record, they may not have done what they need to do to be talking to the bigger system in the correct legal framework. That's one problem. Another problem we have in the United States, a really dumb problem, is that we don't have any sort of national healthcare identifier. So you're trying to match on patient name and date of birth, which is mostly what we're doing. And guess what? There's other
There are
people with
duplicates.
names that were born in 350 million people or whatever up to the United States. There's other people that have your name that were born on the same day. So that's not perfect, but at least it's getting.
It happens, Artur. You are frowning, but I read about the
No,
situation.
I'm frowning because I thought that the social security number is something that the US would be universally using.
Nope, because of we've forbidden the use of social security number for those purposes because then you get into financial fraud. It's extremely easily solved from a policy perspective by having unique identifiers just for healthcare, but for various reasons, probably too long to get into right now. we haven't got there from a policy.
So I wanted to ask you now that so we've scratched the surface of the access to data. How do you see the development of the recent kind of AI ML models? Are they going to be kind of used in this field anytime soon? And how do you see the whole kind of spectrum of problems with data security and privacy being accessed there? Because we've been kind of talking quite a lot, and also in our professional practice, we've been touching on security of data when it comes to using both in-house and outsourced machine learning models. And it seems like there is a whole host of completely new risks that most people are still not tackling properly. So have you encountered this space? And if so, how do you perceive it?
Sure. So, of course, the topic of AI in healthcare is not new. It's just with the recent large language models that just sort of like trumped itself, right? So, we absolutely are concerned about, on the one hand, making sure we're taking advantage of new technologies that can dramatically improve the delivery of healthcare and not sitting on the sidelines, taking a risk-averse approach and then not taking advantage of better medicine. We don't want to do that. And on the other side, you don't want to move so fast that you're doing the wrong things, or you're opening up your protected health information on your patients to the wrong sources in the wrong way that opens you up to significant legal risk. Or another form of legal risk is moving so aggressively that you're actually letting the AI practice medicine, which is a whole other legal risk, right? So, but where are we seeing this?
ChatGPT has passed the medical board licensing exam, I think, in one state.
Yes.
Whereas they tried it in another state and it failed horribly. So
right.
I would say performance is inconsistent, which is exactly what we've seen in practically all other areas.
Even if, and by the way, of course, it's getting better. And the latest one I saw was with Google's called MedPalm 2. It's the second generation of their medical focused LLM, and they did a test where they took all these commonly asked medical questions. They had MedPalm 2 answer it, and then they had real doctors answer it. And then they, in a blinded test, showed both answers to real doctors. And 80% of the time, the real doctors preferred the AI answer to the answer that was written by them. So yes, it's getting good, but that doesn't solve the legal problem of who are you going to sue when you
It's one of the most American things I've heard lately.
Now there are some.
it is the one of the things we always repeat in to our clients, that there should always needs to be an accountable person, because you cannot see a computer, right? Even in simple things like managerial decisions, you always have to have an accountable person signing off the decision. So I totally understand this approach, but as you said, it can be a great supplementary tool, right?
Yes.
The question, obviously, that we won't go too deep into the problem that it's a supplementary tool in terms of information data. It will never replace the human touch, right? Which is so important in medicine.
Yeah, the best line I've heard that gets often repeated about AI in healthcare is AI will not replace doctors. Doctors who use AI will replace doctors that don't use it. So I think that's the appropriate way to think about it. I think the standard of care, which is a term we like to use awful lot in healthcare, better make sure we're delivering standard of care. If everybody else is doing something better, we better catch up, or else we shouldn't be in business anymore, right? Standard of care is where it's safe, legal, and appropriate. You'd better be taking advantage of these new technologies. Here's a couple examples. This is not LLM; it's just AI in general. But imaging is an area where, of course, in terms of FDA approved, AI to improve care is imaging is the area of medicine with the largest number of FDA approved solutions. Okay, so another example, going back to the example of your motor vehicle accident, you're wheeled into the emergency room unconscious, and they're trying to save your life. Okay, or actually, a better example is stroke victims in the emergency department. Okay, there's a busy emergency department. There's 10 patients in there that have to rule out stroke, and the radiologist all of a sudden gets 10 head CT images coming in at the same time. Well, the AI can say, look at number 7 first, because we see a bleed in number 7. And so then you can save that patient's life because you read that faster and took appropriate action. Otherwise, the radiologist is reading first in, first out, right? Because they're all stat. You're supposed to read them as soon as you can. So if you're a hospital that's using that technology and you're a hospital that's not using that technology, which hospital do you want? Right? So that's one.
The closest.
Yeah. Well, yeah, you're right. You're right. Yeah. Yeah. Okay, so they're equidistant. For sake of argument, they're equidistant. So anyways, and then on the LLM side, one thing that's coming very quickly. We're on Epic for our electronic health record, and because Epic has been partnered with Microsoft for a while, they're able to very quickly take advantage of some of the OpenAI technology and what they're doing, and they're already rolling out for beta testing, and the rest of us will have it in 6 months or so, is the ability to one thing that is a contributor to physician burnout, provider burnout, is there are so many now that we've opened up the patient portals and tell patients just write your doctor questions. Is the inbox? Their inboxes are overflowing in the electronic health record for sometimes relatively simple things like, hey, can I get a refill on my prescription? Well, now we're going to have the AI look at the question from the patient, look at the electronic health record, queue up what the provider is likely to say. It's not going to send it automatically, but it's going to queue it up and save a lot of time. And the provider still has to read it, make an edit if necessary, and click send. But that's going to be a lifesaver. I shouldn't use that. It's not really going to save lives. It's going to make doctors' life
time saver,
huge time saver. So yes, these kinds of things are coming, and obviously we're not having AI practice medicine. We're just making it more efficient. Another quote I've heard recently that I think is very true is we need to throw AI at everything except the most intimate part of doctors taking care of patients, so they can spend more time
taking care of the patient,
patting the patient on the wrist, talking to them about what's.
I have a question from I would say more the risk and the technical part of things. So we have this LLMs, we have this imagery. I guess much more data will have to be exchanged with the applications which deal with analyzing all this data. Like, are the technical and legal frameworks that you mentioned already in place, waiting for this to happen? Because you said that in imagery there are already a lot of tools. So I guess it means that these frameworks are already working there. Will they be easily adaptable to text, to I don't know, LLMs, or do you think it requires a lot of work? Because I think that as long as the data is in the hospital, it's safe, it's secured by you, and we don't need to worry so much. I'm thinking about this interface when you get to third party which is providing, because OpenAI, in example, you cannot install it on your premises unless you have your own, I don't know, atomic electricity plant and a couple million processors running, the basement.
Sure. So back to the example of we've already made it much easier for a patient to download their record from their doctors, put it into some third-party app. Let's say they have some chronic disease that is they're going to be able to manage better with the assistance of some mobile app. And now that mobile app is turbocharged by an LLM, so it's going to be even better at helping you manage your diabetes, your asthma, or whatever fill in the blank chronic condition. Okay.
I'm thinking more of the doctors themselves. So you have a patient on your table,
Yep.
and it's, I don't know, rare disease or really atypical case.
Yep.
My both my parents are doctors, so I know that atypical cases are pretty typical, so to speak. So I imagine the situation where the doctors will, because as you mentioned, the patients can download it, they can do whatever, they can print it, and they can wave it over their heads if they wish to. The question is about, the doctor. Let's say there is a technical possibility that he drops some in some format the information about the information he collected from the patient, and he gets some suggestions. It could be a typical version of this or that.
Yes.
So
Yep.
I'm asking about hospital directly taking.
Right. So a couple other things that are so another other functionality has come in, sort of certainly enabled or turbocharged by some LLM technology, is to tell the doctor, hey, since you saw the patient last 8 months ago, here are all the things that happened. And by the way, you've got 3 minutes to look at this before you go in to see the patient exam room as you're running between patient exam rooms. You don't have time to look at every last thing in the EHR, perhaps, but here's a thoughtful summary that the AI has helped put together. Here's the most important. Here's the most important thing. That's something else that LLM is really going to help with, and I think that responsible electronic health record vendors are going to do this. It's not your doctor doing it. It's not your hospital doing it. Quite honestly, it's the electronic health record vendor that's going to put a lot together. Now, back to your point about the doctor seeing a patient for, you mentioned something about a rare disease. That is also going on. Actually, that predates some of the LLM stuff. That's something else that our EHR vendor Epic has been working on for a while. They have a research database of de-identified hundreds. It was up to 180 million patients last time I checked. It's probably getting close to 200 million now. And they can do things like say, oh, we see you're treating this patient with this rare disease. Would you like to talk to other doctors and other health systems that have similar patients?
Cases. Yeah.
Okay. And all you know is that there's some other doctor out there that's treating a similar patient. You don't even know the name of the other patient, but then facilitating reaching out to that other physician. Something else they're working on is, for now, the opposite of that is common conditions, where we have millions of patients with hypertension or common conditions, and you can have really good data on if I'm going to make a decision on which medicine I'm going to prescribe this hypertensive patient in front of me right now, instead of reading the journal article that came out last year that was based on data from 3 years ago, I can now grab data that's as of up to date as of a couple of days ago, and see, for patients like this, and then I'm still going to have a sample size of 100,000 patients that are this hypertension and this medicine, right?
Mhm.
And this medicine might be better than that medicine. So yeah, these tools are rolling out pretty quickly. The last two things that I mentioned are in the process, maybe like within the next year.
No,
It's interesting the speed at which it's evolving, and obviously as you say, the doctors have to catch up with their approach. The companies, the providers have to catch up with their infrastructure, and I think that the patients also, as we discussed, have to catch up with their kind of their care and their acceptance of this technology. Now, moving slightly away maybe from the large language models and different directions of digital healthcare. Do you see other developments in digital healthcare that are currently, I don't want, well, let's use the common word, trending, that where healthcare is developing using new technologies that will change the way that both the patients are treated tomorrow, and also will present you as the chief information officer of a not financial healthcare institution, obviously, a slip of the tongue there, with new challenges to make sure that these technologies are delivered accurately, but at the same time safely.
Sure. So there's, of course, all sorts of digital health innovation going on. In some cases, it's for health systems that are trying to do better for we sometimes call digital front door solutions, right? How do we just make it easier for patients to get to care? And one thing that is certainly true is that as financial institutions and others have dramatically improved the customer experience, people expect the same thing out of their doctor or health system, and so we better be leveraging the tools that we have. Even though in some cases we have to be a little bit more careful about how we do that because of the protection. We still have a responsibility to deliver those kinds of tools, and so more progressive health systems that are keeping up on this these days, when you go to their website, that you can type in, you're not presented with what specialty of doctor do you want, and then you have to know what a nephrologist is, right? What you should be doing, as we talk a lot about health literacy, right? And so patient may not be a highly educated patient, and they are going to type in and misspell the condition that they have or the procedure that they need. And so that digital front door ought to be able to understand what the patient meant to say, and then match them up with a doctor that treats exactly what they have or exactly what procedure that they need. Not just because it's the same specialty, but no, we actually know that the doctor does that. That doctor did 5 of those procedures last week, and it takes your insurance and speaks the language, speaks Spanish or whatever. So that's what state of the art is right now. And then, oh, by the way, also here's some available appointments on the website. Just go ahead and schedule yourself an appointment, and we'll worry about the referral, because we do want to make sure that we're not wasting the patient's or the specialist's time with sending patients to specialists inappropriately. But we'll worry about the referral and all that after you get scheduled, not before. The old model, which is your primary care, put in a referral, and then hopefully the specialist office calls you back. So we don't want that. We want, let me find the doctor that's available that I can watch a little video of the doctor and I feel good about the doctor, and now I can schedule that appointment online. So that's what digital that's what good looks like for digital today.
Just as a comparison, maybe in Poland, I know that to some specialists, if you want to use the public healthcare, but also in private is not much better because there's not enough of them. The lines can be longer than 5 years or 6. So sometimes you need to wait longer. So there is a chance that your doctor didn't start studying medicine yet. So he will. That's
Yeah, but at the same time, you're talking about, because we both come from Poland, and one of the things that I always admire about Poland is that they have the central government created database for patient information access, and each patient that has the national identity number can have a secure profile access online and schedule their appointments, see their prescriptions, see their records. So it is, I currently live in UK, and NHS has been improving a lot, but it's still a quite kind of more traditional than Poland is. So different countries have got are different stages of development. I think there's no country, no kind of first world country that is not doing anything, hopefully, but the countries are different stages of development in this space. And I guess one of the things you mentioned, innovation in all this. One of the things that you have to be careful about, I think, in this is that in other areas, including finance, you can innovate a bit more freely, because when one big
people
part of
don't
innovation
die.
is big part of innovation is failure, right? And even if people go to a bank and are HSBC, which I used to work for, they had this gimmick, frankly, where in the Hong Kong branch there was a robot greeting everyone, and sometimes the robot failed and sent people to the wrong floor or whatever. It wasn't very good, but it was a gimmick. People liked it. If people tried it in a hospital, I think it would meet with a bit of a disapproval. if suddenly it sent you to a different floor and you had a pretty serious condition.
I have a funny healthcare robot story. I saw a presentation when I went to the HIMSS, the healthcare IT show every year, and it was a hospital system presenting on early use. They were really still studying it, about little robots that ran all around the hospital and could go fetch things, basically, to make nurses' lives easy. Right?
Okay.
I've got this medication that's not on the floor. Go down to the pharmacy and bring it back. It's a great use case for robots, right? Well, the investigator for the study was talking to some nurses, asking them how they like the robots, and they said, "Oh, it's great. We send the robots down to get the DoorDash when the patients order meals out, for delivered food, and they said, wait a second, that's not supposed to be happening. The patients are supposed to be eating what the doctor prescribes them from the hospital dietary services, not." So they had this discovery only because they had these robots in the store. Patients were ordering out when they weren't supposed to be ordering. So, but yeah, that's a great example of just going and fetching things to make lives easier for some of our clinicians.
No,
And
definitely.
No patient's gonna die because of that, right? So
Unless the robot fetches the wrong food.
yeah, but you have all sorts of controls. You already have controls. The nurse has to scan the barcode 7 times before they can
administer
issue the
food.
medicine.
I've watched enough House MD to know that there's something that would it's
Exactly.
bound to go wrong.
Yeah, things can always still go wrong.
I would like to go back to the digital healthcare. Like, what is it that we should expect realistically in this area, or what are, because working with technologies, we are very often we meet very often technologies which oversell. The marketing is really heavy. We would like to ask you. We know that you are a consultant in digital healthcare. So we would like to ask you as a professional, like, what should we expect to come, and what we should be wary of, that that is really pushed down our throats, but maybe it's not time yet.
Sure. Well, one thing that healthcare consumers should expect is more convenient care, right?
Mm-hmm.
And so, one of the silver linings of the pandemic is that we got over, we got past the all of some of the inertia of video visits, right, and telehealth. The technology had been there for a while, but through a combination of, at least in the United States, insurance company policies, and in some cases, just some physicians not embracing it or hadn't really tried it yet and weren't quite sure about it. We got over that in a big hurry when that was the only way to see our patients for a while. And so now we're struggling, and at least it's what are the payment policies going to be from the government and from private insurance companies? What are they going to pay for? What are they not going to pay for? When is it clinically appropriate? When is it not clinically appropriate? But there's a lot of great technology out there that just makes care more convenient and still clinically appropriate. So at Dayton Children's, we are using a telehealth device called TytoCare, and they have they just put together a really nice package of sort of a dedicated video visit equipment that has an otoscope for looking in your kid's ear, stethoscope, little camera with a light to look in your kid's throat, so you can have for example, a nurse practitioner on the other end for an urgent care visit. If of course a lot of kids get a lot of ear infections, okay, and we should not be prescribing the antibiotic before a medical professional looks in the ear. Well, if mom or dad can stick the camera in the ear and do the exam, and nurse practitioner that's 30 miles away can do that diagnosis and then and writes a prescription, and mom and dad never have to leave home, then that's a win, right? Those are the kind of things that we can and should be doing, and consumers can and should be taking their business to the health systems that enable these technologies and make care easier.
I've heard that I'm not sure if they performed or planning to perform. There's remote operation as well.
Yes.
Like I wouldn't have a problem with having cameras stuck in my ear. However, my heart would be operated via 5G. I think it was about the throughput of 5G. I can't remember if they operated a banana or actual heart, but one of the two. So I think that the remote diagnosis could be really helpful. Also, I think when it comes to care of the elder people who are probably more vulnerable, and getting to the doctor is also pretty hard for many of them.
Exactly.
So it's the remote diagnostics is really interesting. Is there anything else we should look out for?
Or maybe something that is is actually hyped, but is so overhyped, and we should be wary of the actual efficacy of.
We like to kill buzz. We are pretty old, grumpy guys, and we like to kill some buzz from time to time. So help us here.
Sure. Well, certainly when you look at the investments going into digital health, there's a lot of ideas that sound great. And in particular, a couple years ago, when there was just crazy venture capital going into anything that sounded like it might be a good idea, right? And so people would go design.
Are we talking about full diagnosis from one drop of blood? Not to name.
Yeah, right, exactly. Yeah, and so Elizabeth she's finally in jail now, right?
I'm not sure if she already is. I've heard that she
very
was
very soon, right?
trying to avoid it by having 2 kids within
And
a year.
so one spectrum is complete and utter fraud like that. But then you have people with good intentions that have a 0% chance of actually bringing that thing to market because of a lack of understanding of the way that things really work, or who you're going to sell to, or whether it's going to integrate with the rest of the health system, or integrate with, importantly, clinical workflow. Okay.
Mm-hmm.
And so one thing that's being realized is, particularly on the machine learning side, you may be able to, in an ideal data lab situation, develop a better predictive algorithm, and your area under the curve is a little bit better than the last. But if you can't bring that to market efficiently and integrate it back into the clinical workflow in the electronic health record, it's not going to do anybody any good.
Mm-hmm.
So if you can get venture capital and spend $50 million bringing that to market and then not get any customers, well, okay, you just wasted some venture capital's money. But there's certainly an awful lot of that going on.
Well, but still, this kind of thing should definitely not derail people from trying, because there's very often there's especially with some of the more outlandish ideas, there's really no way of telling upfront whether it will catch on or not. And there are some great examples of things that were quite outlandish when they were thought about, like iPod, cloud computing.
Sure.
They all started as completely, someone sitting in a garage and dreaming, and nowadays we wouldn't live without them. And healthcare, like you said, there's plenty of innovation. Let's hope it's careful innovation, just careful enough so that it really helps people, but at the same time, let those dreamers dream. I wanted to finally ask you about the kind of integration of that innovation into production, because as you said, you mentioned there are startups there, they are trying to do that. Before an idea gets actually adopted by an institution like your hospital, what kind of because quite a lot of our audience is startup kind of founders and entrepreneurs, what should they be thinking about before they try to approach an institution like yours to even consider an idea?
Sure. So at the beginning, we were talking about the interoperability, mostly in terms of from the patient's perspective, but the same standardization of some of the interfacing. FHIR, FHIR, Fast Healthcare Interoperability Resources, is a interoperability standards that the U.S. the government has pushed on us, and this is the good kind of regulation, right? We're just going to agree on some standards, and the granularity with which we can now exchange data just within the last few years has gotten significantly better. And the electronic health record vendors, as they implement that, now this means that if you are a digital health innovator and you do develop something better that can get data in and out, get data quickly out of the EHR, work some magic on it with whatever flavor of AI and remote patient monitoring and application, better UI you want to throw at that, and then get that back into the electronic health record in front of the doctor to take better care of the patient. Now that is much more possible than it was just because the level of effort required by my team, the IT team at the health system, it's not zero, but it's a lot less than it used to be. In the past, we'd see some solution that sounded interesting, but then we'd have to, spend more time and money getting it integrated. It was really worth doing it. So when the friction on that has come down significantly, it opens up the possibility to a lot more and better innovation. So that part's really
I have one
Okay,
last
so
question.
it sounds like kind of pretty. If I may summarize it, like pretty common, pretty common sense advice. Just know your target market and know the standards that operate in this target market. And there is,
Exactly.
it seems like there's already a lot of effort going. Oh, that's great to
Uh,
know.
I have. You mentioned that a lot of effort because when we are talking about patient to doctor interface, there is we don't want to meddle there, but there should be uh, a lot of work put into optimizing everything around it, so the doctor can spend more time with his patients. Do you have an idea, like something that would make, in your opinion, a change or make things easier? So we are talking about these dreamers. Maybe you can point out like some problem, but it would be good if somebody finally solve it using this standards of interoperability or data or any flavor of AI. But from the inside of the hospital, something that people would say, yes, finally someone came with the solution.
Sure. So one of the holy grail things is that every doctor everywhere would love to be able to focus completely on their patient and go about an exam talking to their patients, and then the AI magically documents the whole encounter, right? And then queues it up. Of course, the doctor's still going to have to
Read it and
read
like
it,
with this answer.
edit it, because they're signing it, and if it's wrong, they can get sued for malpractice, right?
Mhm.
But at least it's going to, 98% of the time, do a really good job of documenting that whole encounter and have enough smarts to know when the doctor's talking, when the patient's talking, and what was said, and thoughtfully summarize. Up to this point, the technology has been Nuance, and of course got acquired by Microsoft. Has a solution, but there's still a human being in the middle of that solution. Not just the doctor, but I mean a
Mhm.
transcriptionist type of person that's sort of QAing that stuff. And because of that, it's still relatively expensive.
Mhm.
So Nuance and another, I've seen the Nuance demo. I've seen the demo from a vendor called Suki, SUKI,
Mhm.
that they have both good integrations with the electronic health record and with the latest generations of AI. It's now really getting to a point you don't have to have a human in the middle of that. That means the price can come. And so we are looking at some of these technologies now. That's the kind of thing that I think just within the next couple of years there'll be a real transformation there. If we don't do it, and that the other health systems are doing it, and now doctors are going to leave and go to the other health systems that provide these tools.
All
Well,
right.
so it looks like a good place to kind of summarize, because we've mentioned quite a lot of developments. And it looks like healthcare of tomorrow is not that far away, but there's still a lot of things to be done, and a lot of both patient and doctor education to be accomplished before we actually sit in our home and get connected to our home patient diagnostic kit, and the doctor just gets an AI to do the first kind of history and
Triage.
pre-diagnosis. Yeah, and so, but it is getting there, and it's good to know that even in areas like healthcare, these things are making their headway, and you know it, it's being done carefully with appropriate risk management, tact, and approach to patient care. If people want to learn more about what you're doing and your consulting work, and the areas that you're interested in, how can people contact you, and where can they read more about you and your work?
Sure thing. Well, the easiest thing to say is just look me up on LinkedIn, and I've got some more from there. You can get to. So I do have a side hustle doing some consulting work, specifically helping out health tech vendors that want to understand how to actually sell into health systems, how to go about that, what doesn't, where's the technology headed for interoperability. So those are really fun discussions. Have some dialogue about that. That'd be great.
So hopefully the ones from our audience who are thinking maybe about healthcare oriented startups, they could contact you and learn a thing or two. And as always, well, let's hope it was of use to someone.
Thank you for listening.
Also, don't miss the next one, where we'll be talking to Andrew Batch-Dubner, CIO of First Community Mortgage, about use of data in banking.
Subscribe on your favorite podcast platform or visit pda.show to find out more about future episodes and guests. You can also check out Cognition.llc for more information on Cognition Shared Solutions, our services, and other events hosted by us.
For now, it's thank you from myself, Artur Guja, and my co-host, your friendly neighborhood data guy, Dr. Marian.
Thank you and goodbye.